So next section we're going to talk about some specific drugs that we commonly used in MAC. So propofol, most common one. We love it because it has a short context-sensitive half-time, and even for short procedures, half of midazolam's context-sensitive half-time. Has a short effect site equilibrium time, so it's easily titratable with an excellent recovery profile, excellent quality of recovery, because it has a common side effect of enhanced sense of well-being. Low incidence of post-op nausea, vomiting, but the problem is pain on injection, and it happens quite frequently uh, without us noticing because people just don't say anything. But every once in a while, you see the patient that's screaming, and those are especially the patients that have received minimal sedation, and those are the ones that will be screaming for you. So far, some published strategies in terms of how to reduce the pain on injection, and every single one of them, there is at least a paper saying that it doesn't work. So one of the best options seems to be using a larger vein. So if you give a propofol through a central vein, it's much less likely to cause pain on injection. If you give the injection slower, probably injection into a IV that's running fast. Some say diluting it with a 5% glucose or a 10% intralipid may help. Adding lidocaine to propofol, not a huge fan even though I do it, but I don't do it for pain on injection. I do it for blunting sympathetic reflexes. Pre-treating with lidocaine and venous occlusion. This is one of my favorite techniques. It's kind of like a mini beer block, so I have the blood pressure cuff go up on the same side, stay up, give my lidocaine, give a few minutes before I give my propofol, and usually works, but not consistently. And one of the more effective approaches are actually giving opioids and benzodiazepines. So pre-treatment seems to be more effective. But the question is it getting rid of the pain or is it making the patients too sleepy to complain? Cooling the propofol to 4 degrees Celsius, injection of cooled saline before that, I'm not so sure, but there are some papers that say it may work, others say that it doesn't. And discontinuing IV fluid administration during the injection. So this is kind of counterintuitive with giving the fluid quickly. So I don't know which one's the best, but my favorite is the beer block, mini beer block, and opioids and benzos. So propofol, how do you dose propofol in the obese patient? Do you use the actual body weight? Do you use lean body mass, ideal body weight? And is it different when you give a bolus, or is it compared to an infusion? Do you use different weights? So this is something that we should talk about during the actual lecture time. In the meantime, feel free to read about it. Now, benzodiazepine, we'll use them for anxiolysis, for amnestic properties, and they're somewhat hypnotic properties. And they facilitate people not remembering what's going on. And also, they're very powerful anti-anxiety medicines. We like midazolam because compared to other benzos, it has relatively short elimination half-life and decreases the likelihood of concomitant drug interaction. So basically, we're not stacking dosing if we're not too careful. Even though midazolam has a short elimination half-time, so the drug may be gone, but there is often a significant and prolonged psychomotor impairment after using midazolam, and especially higher dose of midazolam, older patients with brain issues like Alzheimer's patients, those are at higher risk of having this problem with midazolam, and quite often it's manifested as delirium postoperatively. Now, when you give propofol, it reduces the distribution and clearance of midazolam in a concentration-dependent manner. That means when you give propofol, in addition to midazolam, the actual plasma concentration of midazolam is going to be higher compared to when you give the same dose of midazolam by itself. So you got to be careful. So in the elderly patient especially, we have to lower the dose because they are particularly more sensitive to the effect of midazolam, and that has to do with the receptor as well as other pharmacodynamic processes. Benzos enhance the patient's comfort, improve operating conditions, and provide amnesia. We love them for that reason. But recovery of the psychomotor and cognitive function may be significantly prolonged after giving benzos, and especially when it's compared to drugs like propofol. Opioids are indicated when regional or local anesthetic techniques are inadequate or ineffective, and if needed, they should be given immediately before the painful or invasive portion of the procedure. And commonly used opioids in MAC are fentanyl and remifentanil. Do I use it often? I go back and forth. Sometimes I do. Last time I gave this lecture, my answer was no. Today, my answer is sometimes. So, go back and forth. Because if the goal is sedation, we have other agents. If the goal is analgesia, we have other agents. Sometimes those agents are inadequate. Sometimes they are. So, varies by patient to patient and surgery by surgery. Remifentanil is a potent, ultra-short-acting opioid that most of you used already. It's predominantly metabolized by the non-specific esterases with extremely rapid clearance and termination of effect. And the half-time is very context-sensitive. Half-time is consistently short, 3 to 5 minutes, even with prolonged surgery with patients with renal and hepatic dysfunction. Very safe drug and easy to use in those patients. It also has a short effect site equilibrium time of 1 to 1.5 minutes compared to the fentanyl of 4 to 5 minutes and morphine of 20 minutes. So you can give it a minute before intubation and it's going to be effective compared to fentanyl that you need to give 4 to 5 minutes before intubation for it to be effective. Some important points about Remi. It's the most desirable therapeutic endpoint for remifentanil is effective analgesia and patient comfort. It is not sedation. If you use it for sedation, you may significantly overdose the patient. Bolus can result in increased incidence of respiratory depression and chest wall rigidity, especially if you give like more than 3 to 4 per kilo boluses. When you add midazolam, it significantly reduces how much remifentanil you need, so it increases the potency of remifentanil. So again, be careful. Ketamine is a phenycycline derivative. It's an intense analgesic associated with minimal respiratory and cardiovascular depression. Produces a dissociative state. Eyes remain open, with nystagmus case. Increased oral secretion, and if you're not careful, it can lead to laryngospasm because there is secretion there. Patient is disinhibited depending on how much you're giving. So if you're not careful, laryngospasm can be not so much fun to deal with. Now, if you do a PubMed search with the word ketofol, you get a bunch of articles primarily published from emergency clinicians with this word in it. It kind of bothers me, but I think it's kind of a catchy name. So isopropofol and ketamine balance the negative effect of each other. The analgesic effect of ketamine reduces the overall dose requirements of propofol, so it results in preserved hemodynamic stability, decreases risk of nausea and vomiting because you're not using inhalation anesthetic, improves procedural condition, most likely from the additive analgesia that ketamine provides, and decreased airway complications because when you use ketamine combined with propofol, you lose much less propofol, so less risk of respiratory complications. Dexmedetomidine, the alpha-2 agonist, suppresses central sympathetic function and produces sedation and analgesia. The alpha-2 agonists potentiate opioid-induced analgesia, benzo-induced hypnosis, and have potent MAC-sparing effect with volatile agents. Compared with propofol, it doesn't cause any respiratory depression, but keep in mind, patients who obstruct in their sleep apnea, they can obstruct with dexmedetomidine. So there was a paper published not too long ago saying that dexmedetomidine can result in respiratory depression, but what they failed to distinguish was removing the patient with obstruction. So I still strongly believe that dexmedetomidine, even with significant overdose, does not result in any respiratory depression. Dexmedetomidine doesn't cause any pain on injection, but keep in mind it's not amnestic. So when you do the sole dexmedetomidine as your sedation, tell the patient, I expect you to remember what's going on, but I'm going to keep you in the la la land. It is slower onset, so 5 to 10 minutes depending on how much you're giving and the patient factors. So, sometimes in older patient, I start a low bolus rate, like, 0.2, 0.5 per kilo over 10 to 20 minutes in the pre-op before the patient get to the room. So by the time the patient get in the room, they're pretty close to where I want them to be. It can cause significant bradycardia, especially if you give the bolus too fast. And another interesting thing about it is, unlike propofol, the non-anesthesiology trained providers can use it without restriction. So how do you treat bradycardia after a bolus of dexmedetomidine? So this is another thing I want you guys to read about, and we'll talk about it during the lecture time. So bradycardia as a result of dexmedetomidine. How do you assess it and how do you treat it? How about the patient with low albumin or severe liver disease? Do you have to do any modification of your dosing with dexmedetomidine, or do you use the same dose?